Good morning. My name is actually Elad Boaz, and I'm presenting this study. That's okay. I'm an MAS fellow at Cleveland Clinic, Florida, and we present the evaluation of the robustness of randomized controlled trials for the treatment modalities of esophageal cancer using the Fragility Index. We have no disclosures. So a few words on esophageal cancer. It's the 8th most common type of cancer worldwide and the 6th leading cause of cancer-related deaths, with more than 20,000 new cases and 60,000 related deaths each year in the United States. We distinguish between squamous cell carcinoma, which is the predominant type in the worldwide, versus adenocarcinoma, which is rising in incidence in the Western countries. The treatment array continues to evolve with a multidisciplinary treatment approach, which includes endoscopic resection, surgery, radiation, chemotherapy, all in the adjuvant and neoadjuvant setting, as well as the recently approved targeted therapy, immunotherapy, and checkpoint inhibitors. But given all the interventions, we still, despite all these interventions, we still have a pretty poor 5-year survival of less than 25% of patients surviving up to 5 years. The concept of fragility index was first introduced by Michael Walsh and his group from Canada about 10 years ago. And what they essentially claim is, when looking at clinical trials, the concept of p-value is actually too simple, too simple concept to determine whether a treatment intervention truly gives us any benefit in terms of one intervention against the other. So we all know that the difference between significant of a study is 1 point below or above 0.05. But if we look at these two studies, with the numbers that are given, it's hypothetical numbers of two studies with 1 versus 9 events and 200 versus 250 events in the second study. Same significant results, p-value of 0.02, but we understand, and it's clearly understood from these numbers, that adding a single event to the first group will change the p-value from significant to non-significant, whereas on the second group, on the second example, adding even a few events will not change the results from significant to non-significant. So they define the fragility index as the minimum number of patients whose status would have to change, from a non-event to an event, required to turn a statistically significant result to a non-significant result. And to further emphasize this, we understand that a lower fragility index denotes a more fragile results, and it's a problematic issue looking at clinical trials. As we know, it's a challenge to follow up on patients, and a lot of times, as I will show in our study, the number of patients who are lost to follow-up is actually higher than the fragility index. There are a few limitations when we calculate fragility index. So we have to look at two parallel arms. The outcomes have to be binary, and we have to exclude non-inferiority studies. So the aim of our study was to assess the robustness of evidence on different treatment modalities for esophageal cancer derived from randomized control studies using the fragility index. We did a systematic search using the above databases, and we focused on phase 3 randomized control studies evaluating treatment modalities for esophageal cancer, including surgical resection, neoadjuvant, adjuvant chemotherapy, immunotherapy, and radiation. The range of years was from 2000 to 2023, and we focused on binary primary or secondary outcomes and calculated the fragility index and the reverse fragility index, which is the number of events required to switch or change a result from non-significant to significant. This is the Prisma flowchart of our study. So we looked at 4,028 studies, and after implementing the inclusion criteria, we ended up with 21 papers that were included. So 21 randomized control studies. The median study size was 194 patients. Mean follow-up was 66 months, and the predominant primary outcomes that we look at were survival, mainly overall survival, followed by progression-free survival and disease-free survival. This is a breakdown of the focus of the included studies. A third of them were focusing on comparison of different chemotherapy regimens, followed by different neoadjuvant chemotherapy regimens, and the rest almost equally divided between the rest of the interventions. So when calculating the fragility index for our studies, only 5 studies had a statistically significant result with a median fragility index of 6. Most of our studies had non-significant primary outcomes with a median reverse fragility index of 4. And interestingly, in the one study with the highest fragility index of 10, it was still lower than the number of patients who were lost to follow-up during the study time. This figure shows that the sole intervention with a positive fragility index was neoadjuvant chemotherapy. The rest of interventions did not have any significant results, with the least robust evidence for chemotherapy, different chemotherapy regimens, and radiation therapy. In this figure, just again to emphasize the point of loss to follow-up versus fragility index. So looking at the studies, mean loss to follow-up number for studies focusing on neoadjuvant chemotherapy and neoadjuvant immunotherapy showed a higher number of patients lost to follow-up compared to the number of fragility index or reverse fragility index number, suggesting vulnerability of the studies and the results. So we show that the relatively low fragility index in randomized control studies focusing on esophageal cancer treatment with neoadjuvant chemotherapy as the sole intervention exhibiting positive fragility index. And we suggest that the fragility index and reverse fragility index should be incorporated in order to further assess and to help us to assess the robustness of our evidence in clinical trials. And to conclude, the robustness of randomized control trials across different treatment modalities for esophageal cancer is low, and larger scale randomized control trials or alternative assessment should be considered to increase the level of evidence for esophageal cancer treatments. Thank you, and I'll be happy to answer your questions.
Thank you for the presentation. How can we implement the fragility index before starting a study to ensure we have a robust result?
So it's all about the numbers, as you can understand. I think you have to realize, obviously, it's a challenge when we talk about clinical trials and randomized control trials to recruit more patients in order to have a better statistical power. But this is the challenge, and again, I think the most important thing is when we analyze data is to look at the fragility index and the reverse fragility index and to try to better realize what we deal with, and sometimes not to trust the results or, as significant or non-significant, because this affect our treatment choices.
A very interesting study. In your group, are the faculty routinely using this before implementing new trial results, and has it changed your practice at all?
I don't think so, not yet, but we do look at studies differently, and we do try to collect data on different treatment arrays for different diseases. We try to do these studies now on gastric cancer and bariatric surgeries to try to realize, again, the quality of the data that we use it to and implement during our clinical decision making.
Great, thank you very much.
Thank you.